It's fine. So I made one change.
Would you like to see the presenter view? Just to make sure.
I think it's fine. That one?
Yeah.
It's fine.
All good? Thank you.
Thanks very much.
Yes.
Check.
All right. All good? Yeah. Thank you. My brother works there actually.
Oh, great.
Yeah,
Great,
yeah.
Thank
so-
you. Yeah. Oh, yes, thank you. Yes, this is the one.
So good morning, members and guests. It's my honor and pleasure to welcome you at this presidential plenary for the best abstracts. I will do this with Professor Molyano from Indonesia. I have the honor to do this. And we will start with the first speaker. And the first speaker is Dr. Edward Gain from New Zealand. He's Professor of Medicine at the University of Auckland in New Zealand. And he's hepatologist and deputy director at the New Zealand Liver Unit at the Auckland City Hospital. He will talk about efficacy and safety of oral TLR8 agonist selgantolimod in virally suppressed adult patients with chronic hepatitis B, a phase 2 randomized, double-blind, placebo-controlled, multi-center study. Mr. Gay.
Thank you, Dr. Bures, Dr. Molyano. I'd like to start by thanking Dr. Ghani and the organising committee who really have, despite all odds, put on a superb conference. And it's a delight to return to beautiful Bali. So today, on behalf of my co-investigators at the University of Maryland and the University of Auckland and the Gilead Selgonitm study group, I'm going to present the data, the results from the first phase 2 study of the safety and efficacy of an oral TLR8 agonist, formerly known as GS9688, now known as selgantolimod, for 24 weeks treatment in patients with virally suppressed chronic hepatitis B. These are my disclosures. Just to remind you, toll-like receptor agonists are pattern recognition receptors that recognize pathogen-associated molecular patterns, a very important part of the initial host response and linking innate with adaptive responses to infections, in particular viral infections. The two types which have been developed for treatment of chronic hepatitis B are the TLR7 agonists and the TLR8 agonists, specific to show that they have different antigen-presenting cells, different effector cells. The TLR7 pathway tends to activate interferon alpha, and the side effects have seen with these approaches are those related to interferon alpha. What I'm going to talk about today is the TLR8 agonist, and this is a specific TLR8 agonist, selgantolimod. This is a potent inducer of intrahepatic antiviral immunity. It does it 3 ways, as shown here. And for those of you who attended the beautiful presentation at midday yesterday from the Gilead immunologist on these immunological PD effects of GS9688. You get activated intrahepatic myeloid cells, you get inhibition of immunosuppressive cells in the liver with some downregulating of PD-1, and you also get migration, priming, activation, and proliferation of the very important effector cells needed to control and hopefully eliminate hepatitis B infection. And the preclinical data for this TLR8 agonist certainly supports this use in HBV cure strategies. The initial in vitro work showed that 9688 or selgantolimod was a potent inducer of interferon gamma and reduces PD-1, 2 important parts of the PD response. And these cytokines induced by TLR8 agonism do have a potent inhibitory effect on hepatitis B antigens and HBV RNA in vitro. And in the initial animal studies in woodchucks, a high proportion of woodchucks treated with monotherapy achieved clearance of surface antigen, so-called functional cure. So this current study is to evaluate the safety and efficacy of selgantolimod in patients with chronic hepatitis B who are virally suppressed on NUCs. The design is shown here, fairly simple. It was conducted at 2 sites, University of Maryland in Baltimore and ourselves in Auckland. 48 patients, and these were run in parallel, the e-antigen positive and the antigen negative cohorts. Both cohorts were randomized 2 to 2 to 1 to receive either weekly dosing of oral selgantolimod high dose, which is 3 milligrams, low dose, 1.5 milligrams, or matching placebo. Patients were treated, it's a weekly dose, oral dose, for 24 weeks, and they continued the NUC throughout treatment and beyond into 24 weeks of follow-up. The endpoints, of course, safety in this phase 2 study, but also the primary efficacy endpoint was the proportion of patients who had at least a 1 log reduction in surface antigen decline from baseline at the end of dosing, so at the end of week 24. Secondary endpoints were surface antigen loss and e-antigen loss at defined time points during treatment and at the end of follow-up. Also, the proportion of patients, if any, who actually had virologic breakthrough during the study. We were most interested also in looking at the pharmacodynamic responses, cytokine induction, and looking at the effects of, was there a dose proportional increase in the production of IL-1 and the other cytokines, interferon gamma, and with any baseline predictors which determined whether patients had a PD response or not. And finally, we wanted to look at the effects of this approach of TLR8 agonism on T cell subsets in the periphery. So this is the baseline study population, remembering that for the sake of comparison, we're putting the e-antigen positives and e-antigen negatives together. This was a largely male Asian population, although there were a large number of Maori and Pacific Island people recruited at the Auckland site, reflecting our population with hepatitis B. The median surface antigen at baseline was around 3 logs, but there was quite a variation. And the mean HBV DNA, remembering all these patients were established on NUCs, was very low, and in most patients was undetectable, otherwise certainly less than 2 logs, but usually undetectable. Patients had mild disease. We excluded patients with severe fibrosis or cirrhosis on FibroScan, and you can see patients all had normal liver function tests. Looking at the overall safety now is summarized in this table. This is generally safe and well tolerated in this phase 2 study. Most patients had at least 1 adverse event reported, though. If you look at the serious treatment emergent adverse events, there were 4 in this study. There was a perineal abscess, diverticulitis, a single episode of unsustained atrial fibrillation, and those 3 serious adverse events were not thought to be treatment-related. The 4th adverse event, which occurred in our patient, was deemed to be severe adverse event, which was treatment-related and led to discontinuation of the study drug. And that was in a patient who developed anterior uveitis after around 4 doses of selgadolphin. This patient, interestingly enough, told us that he had a family member who also had anterior uveitis, and in fact both of them had HLA-B27 haplotype, which possibly was a precursor of the onset during this immunotherapy. The most common adverse event overall was nausea. This was also seen in the phase 1 study and appeared to be dose-related in that study as well. It's certainly dose-related in this study, more frequent in the 3 milligram, the higher dose of selgadolphin. But this was generally mild. Cases of emesis when they occurred were single, and they tended to disappear after the first or second weekly dose and certainly did not continue during the study. Looking at the primary efficacy endpoint, which was a 1 log reduction of surface antigen from baseline, that was achieved in only a single patient, and this was a patient who received the lower dose of selgadolphin, who was e-antigen negative. There are a number of patients who had small, but we regard as clinically insignificant reductions in surface antigen on the low and high dose of selgadolphin, and that was not seen in the placebo arm. So certainly some effect, but modest. Looking now at surface antigen and e-antigen loss, there was a single patient who achieved surface antigen loss in the e-antigen negative arm, and there was a single patient who achieved e-antigen loss, obviously in the e-antigen positive arm, at the lower dose of selgadolphin. No patients achieved breakthrough. All patients continued their nuke, remember. And looking at the waterfall plot, this color-coded e-antigen negative is in blue, e-antigen positive is in green. The lighter shading is the lower dose of selgadolithium. The darker shading is the higher dose, the 3 milligram. And you can see our single patient here who lost surface antigen. That patient lost surface antigen early after around 4 weeks of treatment. I should point out there have been additional cases of surface antigen loss and E antigen loss during the follow-up period of the study, and I'll be presenting that data later this year, hopefully at EASL. Now, if you look at the PD, the pharmacodynamic effects, the effects on cytokine induction, and the peak effects occurred at around 4 hours after oral dosing. This is GI activated, this oral dosing, so we get the increases in cytokines very early on. And you can see that this is certainly a dose response. Green is a lower dose, blue is a higher dose. And for all the cytokine markers, IL-12V40, IL-1RA, and interferon lambda, the higher the dose, the higher the PD effect. And this looks at the during the study. Now, this isn't all the weeks. What we've done here is we've taken the first dose here, the dose after halfway through the study, week 11, and then PD after the final dose at week 23. And you can see that there's no tachyphylaxis, that the increase in the cytokines occurs, peaks at 4 hours post-dosing, no matter where you are in the study, and rapidly disappear, and there's a dose response throughout the study. So certainly no tachyphylaxis with the weekly dosing. Looking at the baseline predictors of the PD response, all I can say here is we looked at several, only 2 were found to be clinically significant. That was the dose. The most important predictor of the cytokine increase was the dose, and the only other predictor which was significant was the BMI. The lower the BMI, the higher the cytokine response, presumably reflecting exposure. There was, however, no close association between the PD response, that is the cytokine increases, and the surface antigen decline. So we did not see this in this study of 24 weeks dosing. There are also changes in the peripheral immune compartments. If you look at the immune cell subsets, the CD14 macrophage, monophage, you can see that there's a marked increase in macrophages and monocytes detectable in the peripheral blood at around the peak time of the PD at 4 hours post-dosing. And that may reflect release from the marrow. You can also see there's a reduction at the same time in CD3 positive lymphocytes occurring at 4 hours post-dosing, and we would hypothesize, this is PBMCs, that this reflects trafficking into the liver. This needs to be confirmed, obviously, with FNAs. And if you look at the patient who lost E antigen, you can see that the E antigen loss was preceded by an increase in NK cell activation and a reduction again in CD8 cytotoxic T cells from the peripheral compartment, presumably, we think, trafficking into the liver. So to conclude, Mr. Chairman, ladies and gentlemen, oral selgadolithium, the first oral TLR8 agonist in this phase 2 study, was safe and well tolerated. Very small numbers of patients achieved surface antigen 1 log declines, surface antigen loss, or E antigen loss at the end of treatment, and the post-treatment results will be presented later this year. There was clearly a dose response between the selgadolithium and the cytokine peaks, as well as shifts in peripheral immune cell subsets in those patients with chronic hepatitis B. And we're now evaluating the same study design in patients who are treatment naive. Thank you.
Thank you, Dr. Gain. There is time for one question. May I have this question? It was an interesting presentation, but you mentioned the patient who developed anterior uveitis, and yes. I don't know in your cohort or in your community the HLA-B27 positive rate. I don't know. do we have to be probably careful.
Yes.
You can expect it because you activate the NK cells and so forth.
Yes.
Do we have to exclude patients with autoimmune background?
I skipped over the exclusion criteria. Very tight exclusion criteria for patients with a history of autoimmune disease.
Yes.
We do all the autoantibody markers,
Yes.
including obviously tissue autoantibodies, ANA, thyroid antibodies. We haven't up until now been looking at HLA-B27.
Yes.
The prevalence, I would have thought, in our community is very low. In retrospect, with a family history of uveitis, if we digged a bit deeper, we may have tested the patient, and subsequently the patient's relative who was tested and also found to be positive after the study.
Yeah. Thank you. Yeah, don't see questions from the audience, but last question, fibroscan threshold in your, you said fibroscan threshold?
Yes.
You said serious fibrosis or cirrhosis. What was the threshold, the kilopascal?
I recall it was around 8. We excluded patients above 8.
That's very low.
Yeah. These were very mild disease.
Yeah, very mild. Yeah.
Yes.
Thank you.
Henry,
Another question, yes.
Yes, Vincent Wong from Hong Kong. Excellent presentation. Thank you very much. So can you comment on ALT flare related to treatment?
Well, Vincent, we didn't see ALT flares in this particular study. And whether we're not seeing enough PD response of monotherapy or not, but up until now, we haven't, with this approach, seen ALT flares.
And do you think a weekly dosing is the optimal interval?
The PK-PD studies, the phase 1A and B studies, looked at a variety of different approaches, and certainly this appeared to be the best approach. There was no evidence of tachyphylaxis if you gave it weekly, and I think there was if you gave it more frequently.
Thank you.
Yep.
Thank you very much.
Now we invite Dr. Dickens Theodore. He is a senior director at the clinical development at GlaxoSmithKline. He has worked early phase and late phase development across a number of therapeutics areas. He will present his study about hepatitis B surface antigen reduction with ISIS 505358 in treatment-naive chronic hepatitis B patients, phase 2A randomized double-blind placebo-controlled study. Please, Dr. Theodore, time is yours.
Thank you, Dr. Murjano, Dr. Bowers, members of the audience. I'd like to thank the APASL Organizing Committee for allowing me to present the study results on behalf of the authors who were unfortunately unable to travel. I'd also like to take the opportunity to thank the study participants, the study staff, and the site staff, without whom this work would have been impossible. Here are my disclosures. So, hepatitis B surface antigen is believed to play a major role in persistence of hepatitis B virus infection. Therefore, therapeutic modalities that directly and substantially reduce levels of surface antigen are likely to have a major impact on achieving sustained surface antigen loss or functional cure. ISIS 505358, now known as GSK 836, is a 2' MOE modified antisense oligonucleotide, or ASO, targeting all HBV RNAs. The figure on the right depicts the mechanism of action of antisense oligonucleotide. After entering the cytoplasm, ASOs are shuttled about using a number of different trafficking systems. And you can see from the slide that there are many steps at which the ASO can exert its action, but probably the most important is related to RNA H1 degradation. So GSK 836 binds to its target mRNA in the nucleus, And the ASO RNA hybrid is recognized by RNase H1, which induces cleavage of the HBV RNAs. This ultimately results in reduction of all HBV proteins, including surface antigen. GSK836 was specifically selected for clinical studies based on its activity against hepatitis B surface antigen in non-clinical studies. GSK836 was previously evaluated in healthy volunteers. It was administered in single ascending dose and in multiple ascending dose for up to 4 weeks. The current study was designed to evaluate the antiviral activity and the safety of GSK836 in patients with chronic hepatitis B. And in this study, just like in the multiple ascending dose healthy volunteer study, it was administered over 4 weeks to treatment-naive patients. This slide shows the study design. The patients were recruited in sites from Hong Kong and South Korea. After a 4-week screening period, subjects were administered GSK836 by subcutaneous injection on days 1, 4, 8, 11, and then weekly thereafter. We evaluated 2 doses of GSK836, 150 milligram and 300 milligrams. The randomization was 3-to-1 in favor of active. The primary antiviral assessment was performed on day 29, which was 7 days after the last dose of GSK836. And then subsequently, all study participants were given nucleoside analogs. Most of them received tenofovir. The exclusion criteria are listed here. Patients had to have chronic hepatitis B. They were treatment naive. Both E antigen positive and E antigen negative disease were enrolled. The hepatitis B DNA had to be at least 2,000 international units per milliliter, and the surface antigen had to be at least 50 international units per milliliter. Patients were excluded if they had evidence of liver cirrhosis or co-infection with hepatitis C, Delta virus, or HIV. And here are the demographics for the patient population. The patients tended to be middle age, Asian, since that was where the study was conducted. The median surface antigen was approximately 4 logs, or 10,000 international units per mil. Again, both E antigen positive and E antigen disease were reflected. The median DNA was approximately 8 logs. As you would expect from patients in Hong Kong and South Korea, the genotype was genotype B or C. And this slide shows the primary results. There was a significant mean reduction in both surface antigen and HBV DNA at day 29. You can see a bit of a dose response here. The placebo subjects had no reduction in surface antigen. In the 150 milligram group, you had about a 0.5 log reduction in surface antigen at day 29. And in the 300 milligram group, you had a 1.6 log reduction in surface antigen at day 29. And this was clearly statistically significantly better compared to placebo. Likewise, for HBV DNA, you had no change in HBV DNA in the placebo subjects, a 0.4 log reduction in HBV DNA in the 150 milligram group, and a 1.7 log reduction in HBV DNA in the 300 milligram group by day 29. And again, this was statistically significant compared to placebo. Looking at the data in a different way for the individual patient curves, what we can see with surface antigen response is that you really do have a dose response. Both E antigen positive, denoted with E, and E antigen negative subjects responded to GSK836. The response was a bit variable, but you did have patients, particularly in the 300 milligram group, who had robust reductions in surface antigen. And the last two patients, you can see, actually achieved surface antigen reductions below the limit of quantitation. This patient here also achieved an HBV DNA below the limit of quantitation. And again, this is before starting the nucleoside analog at day 29. We wanted to understand some of the primary drivers of response. And as you know, studies with interferon in particular have shown that patients who have a lower surface antigen pre-treatment are more likely to respond. So this was something that we were interested in evaluating. Again, as you can see here with the different cohorts, the placebo, 150 milligram and 300 milligrams, you have a dose response such that patients who started off with lower surface antigen were more likely to have a robust response, suggesting that this is something that we'll have to evaluate further in the future. One of the things that we're all interested in seeing is whether or not the reduction in surface antigen is associated with ALT increases. And this is a typical patient in the study who had surface antigen reductions and also had ALT increases. What you see is that the surface antigen reduction, there's a robust surface antigen reduction, a robust decline in HBV DNA, followed by an increase in the ALT. There is a little blip in the ALT prior to the bigger increase in ALT, but this really is suggestive of a therapeutic flare. We have a number of patients who had this type of profile. In this particular patient, this patient had a prolonged surface antigen loss up to 3 months after the last dose of the GSK 836. There were no changes in bilirubin, albumin, RNR. The patient was asymptomatic. And so we also had flares in a number of other patients who had at least a 3 log reduction in surface antigen. The adverse events are listed here. There was one serious adverse event reported, and this was the patient that I just showed you with the increase in ALT. Again, the ALT increase was asymptomatic and associated with decreases in surface antigen and HBV DNA, but because the ALT was 700 or so, it was reported as a serious adverse event. There were no adverse events leading to dose reduction, treatment discontinuation, or study withdrawal. We did see local cutaneous injection site reactions, but all the AEs tended to be grade 1 or grade 2. So, Mr. Chairman, ladies and gentlemen, I'd like to conclude by saying that the study showed a significant inhibitory activity against surface antigen and HBDNA with 4 weeks of treatment. In fact, 2 subjects achieved surface antigen loss at day 29, although this was not sustained indefinitely. 1 subject had surface antigen reduction below the limit of quantitation that lasted 3 months after the last dose. The ALT flares tended to occur prior to the reduction in surface antigen, and then the tolerability and safety in this trial were acceptable for proceeding with longer treatment durations. Thank you for your attention.
Thank you very much. Is there any question? Okay, yeah, please.
May I have a question? You showed the patients with ALT flare. Was this associated also with a coagulation disturbance? So did you measure prothrombin time, for example, in these patients?
Yes, we did measure prothrombin time, and there was no change in prothrombin time.
Okay, thank
you. One question for me. So, after a treatment-free period, have you seen any flare or relapse or recurrence?
So in the treatment-free period, we did see relapse of the surface antigen. In one patient, the relapse occurred after 1 month, and then in the patient that I showed you, the relapse occurred after 3 months. We did not see subsequent flares after these initial flares that I showed you.
Okay, thank you. Yeah. Any more questions? If no, thank you very much, and we proceed with the next.
Yeah, the next speaker is Professor Grace Wong from Hong Kong. She's professor of the Chinese University of Hong Kong at the Department of Medicine and Therapeutics. And she will give a talk on CHI3L1 as a non-invasive marker for effective selecting of chronic HBV patients with normal ALT level but with advanced liver fibrosis for treatments. Dr. Wong.
Thank you. Thank you, Chairman, for your kind introduction. Good morning, ladies and gentlemen. I'm really honored to present this work on behalf of Dr. Barang Lin, who cannot make it to this trip. World Health Organization, WHO, set the goal for hepatologists us that we should treat 80% of the chronic hepatitis B patients who are eligible for treatment by year 2030, which is 10 years down the line. But as shown in the graph, that around the world there are so many infected patients, but there are huge gaps in terms of diagnosis as well as treatment. One of the difficulties is to identify who are eligible for treatment. So the question is to treat or not to treat. According to the latest international guidelines, we set HBDNA more than 2,000 IU per ml, as well as ALT more than 2 times of the upper limit normal as a clear treatment indications. However, we often encounter patients fall into the gray zone. For example, they have minimally elevated ALT or even normal ALT, but some of them may already have moderate to severe inflammation or fibrosis. So in this case, the guidelines usually would suggest us to perform liver biopsy, which I would say that is a bit costly, as well as there will be some risk to the patients. Like shown in this study, in fact, more than 30% of the chronic hepatitis B patients with relatively low or normal ALT, in fact, already have significant liver fibrosis or necroinflammation. So which means that there would be quite a lot of patients who would be out of our radar that, in fact, they should deserve treatment. Chitinase 3 lipoprotein 1 or CHI3L1, previously also known as YKL40, is a biomarker which identifies patients with fibrosis stage over stage 2. So like in this study, in fact, CHI3L1 have a very good diagnostic accuracy to identify patients with significant fibrosis. In fact, the AURC in this study was very impressive. It's more than 0.9, which is obviously better than other fibrosis marker like FIB4 or APRI. This biomarker also may predict or correlates well with progressive liver fibrosis. Like here in this study, dynamic changes of CHI3L1 can monitor the speed of fibrosis progression with high sensitivity and specificity over 95%. And CHI3L1 changes in parallel or even preceding the change of liver fibrosis stage after antiviral therapy in these patients. So like in this cohort of patients, at baseline, the CHI3L1 is generally quite high, but after 72 weeks of treatment, in fact, it will drop quite significantly. And these changes even precede the histological changes of liver fibrosis. And the previous study also defined 79 nanogram per ml is the optimal cutoff to discriminate patients with fibrosis above stage 2. Like here in this study, in fact, again, very impressive AURC, more than 0.95. So in the current study, Dr. Lin recruited a cohort of patients, 61 chronic hepatitis B patients, and among them, 43 patients have relatively active disease, like with necroinflammation or fibrosis above grade 2 or stage 2. And among these 43 patients, 20 of them have the G3L1 above the predefined cutoff, 79. But if we set slightly lower cutoff, like 53.5, we may be able to identify even more patients, like up to 70% of patients. All these patients have normal ALT to start with, ALT below or at 40 U per mil. Per liter, as well as these patients, in fact, were put on treatment. And the table on the right-hand side show that, in fact, after treatment for 12 weeks, in fact, G3L1 would drop significantly in almost all patients, but only one. The last patient was a bit special because he also took some other Chinese herbal medicine. But in general, in fact, G3L1 would drop very nicely after antiviral treatment, which can be a signal that there is improvement in liver fibrosis. So in summary, this study showed that this new biomarker G3L1 will be helpful for us to identify patients who will have treatment indication which otherwise we may not know. So now we have the goal to treat 80% of our patients who are eligible in these upcoming 10 years. And the problem of under-treatment is that we may not biopsy them and we may not know they really have active disease or advanced fibrosis. So we will make use of some non-invasive assessment. Like in this study, we show that these biomarkers will be helpful for us to identify patients with liver fibrosis above stage 2. We may make use of the cutoff of 79 nanogram per mil. If patients have such a level of the biomarker, then we may consider treatment. But for those who have the biomarker lower than this cutoff, we will monitor them, and probably we can repeat this biomarker regularly to see whether they will fulfill the treatment criteria. And hopefully, in the upcoming years, we may identify more patients and put them on treatment and can achieve the WHO goal really on time. So with that, I thank you very much for your attention.
Thank you very much for this interesting presentation. There are certainly questions on that. Please.
Okay, very interesting presentation. According to your last table, I think the sensitivity would be around 50% at the original cutoff and just over 70% at the new lower cutoff. How about the specificity?
Right, okay. So I would say that for that particular study, that may I go back, this is a relatively specific cohort that all of them have a normal ALT to start with, which is a bit different from the previous study because previous they also include the patient with slightly elevated ALT. So I think that's the slight difference here. In fact, the specificity is also very high. It's more than 90%. Thank you.
Hi, Grace. Ed Gain, Auckland. Fascinating. So just remind me, this is if you do a one-off test in somebody not on treatment, is this a measure of the amount of fibrosis at that time point?
Right, yes. In fact, the measurement is at the baseline or before treatment.
Yes.
In fact, this biomarker is the growth factor of the fibroblast, which is involved in the remodeling of the fibrosis. So you may say it's a measure kind of the fibrogenesis or fibrolysis process, may not exactly the amount of fibrosis, but it's more about the active part of the fibrosis.
And how does it compare to FibroScan? You know that in FibroScan, when you put somebody on treatment, often the liver stiffness drops dramatically as the ALT normalizes and the inflammation or water content goes down quickly. Is this affected by inflammation, the ALT level?
Yes, yeah, it is an excellent question. I think that would be interesting to explore that. In this particular study, they do not provide FibroScan data, so we cannot have head-to-head direct comparison. But based on the biological features of this marker, this should not be directly related to the ALT level. But I agree with you that if there's active inflammation and necroinflammation, probably this biomarker will be also slightly higher. So I would agree with you that the change may be partly because of the improvement in necroinflammation.
And in the untreated patient, well, I think its best utility would be to look at what happens over time. Yes. What interval would they suggest you repeat the test?
Yes, I think that would be an important question to address. I would say that at this moment, all of the study are more cross-sectional.
Yes.
They do not have prospective study. I think that would be an interesting study to perform. Thank you.
For you to do. Thanks.
Thank you.
Yes.
One question for me. Did you see any influence of other comorbidities like BMI or other metabolic syndromes?
Right, right. Yeah, I think that's an excellent question. That in this particular study, they do not have this analysis according to different patient characteristics. But I think that would be nice to have a look on that. And according to the biology of this, it's more about the growth factors of the fibroblast. So I believe that there may be no major influence of the BMI on that. But that would be interesting to look into it. Thank you.
If I may add one more question to this interesting data, and Professor Gain already took two of my questions. So, but shouldn't you even think about using a placebo control to verify our data?
Right,
that
right.
You don't have non-specific effects on your marker. The data are impressive, but to further validate that.
Yeah, I think that would be an excellent study design. We should have one cohort remain untreated and treated, and then with interval monitoring of this biomarker. That would be very valuable data.
Yes.
Thank you.
If there are no more questions, thank you for this
Thank you
very
much.
interesting
Thank you.
contribution.
The next speaker will be Dr. Vasily Isakov from Russia. He is the chief of gastroenterology and hepatology at Federal Research Center of Nutrition, Biotechnology and Food Safety in Moscow. He will present his study on the preliminary result of phase 2 study, 100% of SVR rates following 12-week treatment with naraprevir, ritonavir, and sofosbuvir in combination in patients with HCV genotype 1 infection. Please.
Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizing committee to choosing our abstract for the oral presentation at plenary session. And my talk today dedicated to the preliminary results of phase 2 registrational trial for evaluating the efficacy of naraprevir, ritonavir, and sofosbuvir in Russian HCV genotype 1 patients. This is a multi-center trial involving the 5 centers in Russia, and I represent the data on behalf of all my co-authors. You can see them, the names here. This is my disclosure. Maybe as you know, Russia is a quite big country. We have 146 million population, and practically around 5 million people from the population as they are infected with HCV. And the genotype 1b is a predominant genotype. The majority, or nearly half of the patients, they're infected with genotype 1. And in such populations with a big prevalence, high prevalence of HCV, the problem of elimination is very strict because we are restricted with the cost of drug and access to the treatment. And for the elimination program, it's necessary to use the generics or to develop the local products that will be produced and have a low price and available for all the people. And so this trial is specially planned to evaluate the efficacy of locally produced protease inhibitor and sofosbuvir for the future use in an elimination program in Russia. So the two drugs, a combination of two drugs was used. The first was naraprevir. This is a potent protease inhibitor. It was first developed by Schering-Plough, but then was licensed by Russian company, and all clinical development were performed in Russia during the last 4 years. This is a one daily oral product, 200 milligrams, co-administered with ritonavir. And naraprevir is already approved in Russia for the use with pegylated interferon and ribavirin. The second drug of the combination is sofosbuvir, well-known HCV polymerase inhibitor. It's used one daily orally for 400 milligrams. As I mentioned already, the study goals and objectives. The study goal was to evaluate the safety and efficacy of combination of naraprevir boosted with ritonavir with sofosbuvir for 12 weeks and 8 weeks in Russian patients with chronic HCV infection infected with genotype 1. The study design was straightforward because it was open label study. The patients were allocated in two groups. The cohort A, it's a 60 patients that used naraprevir plus sofosbuvir during 12 weeks. And then SVR4, SVR12, and SVR24 was evaluated. The cohort B, the exploratory cohort, enrolled 25 patients with low viral load, less than 1 million international units per mil, and they used the same combination for 8 weeks with subsequent evaluating of SVR4, 12, and 24. All the patients who enrolled into this study, they were treatment naive because, as I mentioned, we proposed to use this combination in the future for elimination program in Russia. The baseline demographics and patient characteristics is here. You can see that the mean age quite low, 44 years old, because the majority of all the patients, they are already on treatment now in governmental program or clinical trials. And the predominantly patients were female. It's also a little bit surprising because men is usually more often infected than women. But in this study, it was so. The METAVIR score of the patients, you can see the distribution there. Mild disease predominant. It was evaluated by FibroScan with a cutoff level of F4 by 12 kilopascal. 59 patients were Caucasian, and one patient race ethnicity was not defined into the medical documentation. The most of the women were capable of the childbearing, 24 from 40, and the contraception was used to prevent pregnancy and very well controlled during the study. What is the results? As you can see, their viral load decreased very quickly. And by the week 6 of the treatment, all the patients were PCR negative. And also after the 12 weeks of follow-up, SVR12 was 100%. No patients prematurely discontinued the treatment, and no viral breakthrough or relapse were noted. The safety, any adverse events was registered in practically one half of the patients, but there is no serious adverse events and no deaths. It's not mentioned in this table, but the grade adverse events was very low. There was no adverse events grade 2, 3, or 4. All adverse events listed here, there's adverse events grade 1. And you can see that the most common adverse events was diarrhea, lymphocytosis, fatigue, weakness, and hyperglycemia. Because there was open studies, there is no placebo arm, but if we compared this data with historical control in a placebo-controlled studies, this is very, very similar to those distribution of adverse events as we found in a placebo groups of previous studies. And in conclusion, ladies and gentlemen, the combination of naratriptan, ritonavir, and sofosbuvir for 12 weeks resulted in 100% SVR and well-tolerated by treatment-naive, non-cirrhotic patients with chronic hepatitis C infected with genotype 1. No unexpected discovery or safety signals were registered. The availability of the effective and well-tolerated short-duration therapy would be a major advance for the treatment of HCV genotype 1 infection in Russia, and hope to promote the elimination program in my country. Thank you very much for your attention, ladies and gentlemen.
Thank you very much.
Yeah, Dr. Gain, congratulations. You can't fault 100%. I think that's fantastic. But you mentioned the subtype split in your country. Did this involve both 1A and 1B?
Yeah. All these patients, they were 1B, because the 1A is very rare distributed in Russia.
Okay.
And mainly 1A patients, they are concentrated in a co-infection group with HCV, HIV. But co-infection was exclusion criteria for this study, and it because all the patients, they were 1B.
It might be quite important, though. We know from the first generation DAAs from Merck and from AbbVie, Vicuripac and Zepotia, that the results in 1B were far, far higher than 1A. and that's thought to be related to the efficacy of the protease inhibitor. But I mean, if your patients are 1B, it's not an issue. The other question was, this was a non-cirrhotic study, obviously, but I presume this is a protease inhibitor like all protease inhibitors. You'd have to be careful using it in patients with advanced cirrhosis or decompensation. Is that right? Could you use it in patients who had liver failure, or is it?
If you ask about this drug.
Yes.
Oh, yeah. The problem is that the protease inhibitors, you know, it's a little bit
So it's a
tricky.
family,
in cirrhosis. But we had the trial, the pharmacokinetic trial with nirmatrelvir in liver cirrhosis patients, child PUA. And it was published in Antimicrobial Agents and Chemotherapy 1 year ago. So possibly we plan to do the small study, but actually we do not have so much liver cirrhosis to treat with this drug because we have all other drugs approved in Russia, like Epclusa and any other combination that more safely to use in cirrhotic patients. And for cirrhosis, the government covered the treatment for the patient, so this combination, they are available. So this combination, preferably, we plan to use for the elimination program because the components will be quite cheap.
Thanks. Congratulations. Great.
Thank you.
Thank you very much. Is there any more questions? If there is no more question, we conclude this and thank you for your presentation.
So now we have a challenge because yes, it works. Guten Morgen, 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 morgen.
I just hear the echo. Hello.
Yeah, it's nice that we have you on our screen. We can see you very well. I first have to introduce you, Dr. Thomas Racek from Switzerland. He's head of the lab for genetics and genomics at the Roche Innovation Center in Basel in Switzerland. And that was the reason why I said Guten Morgen, because we probably speak the same language. I want to tell you that it's 2 o'clock in the morning if I calculated it right. So thank you very much for being available at this time. Dr. Racek will give a talk on transcriptional response to RO70200531, a novel double prodrug of a toll-like receptor 7 agonist in whole blood of healthy subjects and chronic hepatitis B patients. Dr. Racek.
Thank you very much for this introduction, and thank you very much to the organizing committee, to the chairman for giving us the opportunity to present our work. I found it very pity not to be there directly with you, but it's because of all the travel restrictions, but it's really wonderful that we can at least share our data, share some of our results via the video conference. So, as you already told, would like to share really the results about the transcriptional response that we could observe from our double prodrug TLR7 agonist study in whole blood healthy subjects and chronic HBV patients. The TLR7 agonist, RO70200531, is having affinity for the TLR7 and some weak affinity also to the TLR8. It is a drug that is under development at Roche as a component of a combination regimen to cure chronic HBV infection. TLR7 agonism can drive anti-HBV effect through augmented host immune activity via T and B cell activation, mainly by cytokine production. We were running currently 2 studies, one global study and one study in China and Hong Kong with a single and multiple doses of this oral prodrug up to 170 milligram. We found to be this drug to be safe and acceptable tolerability in those studies. Now something about the global study and actually objective of our analysis. The global study started with single ascent 170 milligrams, where we actually observe pharmacodynamic signals measured by interferon alpha and activation or upregulation of interferon stimulated genes with 100 milligrams. And then we selected those doses, 100, 140, and 170 milligrams for the multiple dosing, where we dose QOD, so every other day. In part two, we were treating the chronic HBV patients with the dose 150 and 170 milligrams, and those were patients that were treated also with nukes. And currently, it is ongoing. Move this. Currently, the last cohort 4, is ongoing with 150 milligrams in the nuke-naive patients. So what we wanted to do, apart from our standard analysis in the study, we wanted to explore more the pharmacodynamic effect by using RNA sequencing of whole blood from treated subjects. We used Illumina sequencing after the globin depletion. And we selected subjects or samples from subjects from healthy volunteers based on their transcription level of ISG15 6 hours post-treatment. And we selected 14 samples that have more homogeneous response, that have highest response. And then we took also samples from chronic HBV patients from the cohort 1 treated with 150 milligrams to analyze those by RNA sequencing. Here's something to the pharmacodynamic response that we observe with our TLR7 agonist. And here it's also a very interesting phenomenon. In the left panel, you can see interferon alpha levels measured in serum in healthy volunteers, 100, 140, 170 milligrams, and in chronic HBV patients, 150 milligrams. And what you can see is those related response in healthy volunteers, but somehow we could observe that with chronic HBV patients, we obtain higher interferon alpha levels with 150 milligrams than it was with 140 milligrams. That is somewhat comparable dose in healthy volunteers. We seen similar phenomenon also if we were looking on IP10. Nevertheless, if we were looking on the transcriptional signal, and here it's represented by ISG15 measured by qPCR in the fluidigm panel, we see actually dose-related response in healthy volunteers, but in the chronic HBV patients with 150 milligram, is the response very comparable to the healthy volunteers with 150 milligram. So we selected samples first from healthy volunteer subjects, 6 hours, 12 hours, 24 hours post-dosing, and performed the RNA sequencing. Here you can see principal component analysis that it's serving also as partly as a QC for the RNA sequencing, and you see actually cluster of clustering of the subjects based on the time point. The 6 hours and 12 hours are rather clustering together. This is also, those are also the time points with highest response, and 24 hours and baseline actually clustering rather on the other side of this PCA plot, where the response is 24 hours post-treatment, post-dosing, returning back to the baseline level. Here on the in the lower panel, you can see so-called volcano plots, where actually it's plotted the log 2 fold change against logarithmic p-values to demonstrate actually significantly deregulated genes at this contrast baselines versus 6 hours, baselines versus 12 hours, and baseline versus 24 hours. You can nicely see that majority of genes that are deregulated in those treated subjects are actually 6 hours post-treatment. It's around 402 genes that are upregulated, and there is minority or 87 genes. Minority of genes are also downregulated, but on the border of the significant. 12 hours, we see still very good pharmacodynamic response, at least on the transcriptional level. And 24 hours, as I said, the magnitude of the response is dropping. The transcriptional levels are returning back to the baseline. We were using the molecular signature database to actually cluster the genes and transcripts from those subjects, from this analysis based on their function. And you can here on the left panel see the enrichment analysis, pathway enrichment analysis for the healthy volunteers for the chronic HBV at a given time point. And you see the major pathway and major response we can observe from this analysis from the subject is actually the interferon alpha and interferon gamma response. This is of course not surprising. Same for the inflammatory response, IL-6, JAK3 signaling pathways. Those are all responses that are related to the interferon alpha response. Maybe some explanation regarding the interferon alpha and interferon gamma response from those that know a little bit more about the biology of interferon alpha and TLR7, the type 1 and type 2 interferon is very overlapping. If you look on the signature, on the molecular signature transcripts, there are many transcripts that are actually regulated by both interferon alpha and interferon gamma response. Here in the signatures, also those pathways are overlapping. Therefore, they are coming in this analysis as both significant. It doesn't necessarily mean that we are having strong interferon gamma regulation or some transcripts that are rather related to interferon gamma response, but many transcripts we observe are specific for alpha or could be specific for alpha and gamma response as well. If you look at the interferon response genes on the gene level, we can actually see very clearly 6-12 hours, and this is really the magnitude of the response. 6-12 hours post-treatment is the highest magnitude of the response, dropping 24 hours, so latest 48 hours post-treatment to the almost normal level. And can actually very clearly see that there is a cluster of genes that's showing similar response levels between the healthy volunteers and chronic HBV patients. It's somewhat interesting and surprising, and we are really digging deeper into that, and more analysis is also needed to see actually some specific response, either in healthy volunteers or some stronger response in chronic HBV patients. We still can't tell really that whether it's because we have very heterogeneous response in those subjects and a relatively small number of samples that we are analyzing, or is it really something related to the biology and fact that those subjects are infected that the response is somewhat different. What we could also observe, it's maybe not so clearly demonstrated in this picture, is immune priming and boost with the second and following doses. In some subjects, we see actually that the response 6 hours post-treatment, post-dosing, the first dose is a little bit lower, but quite significantly boosted with the second dose. And this is also why QOD is so interesting for the treatment with this compound. We were looking also on the immune cell signatures and changes in the cell composition and activation status of the cells. Of course, we are having a limited number of time points to see the full kinetic of the activation and changes in the composition. On the other side, as example here for the T cells, the enrichment signature for T cells is dropping, is decreased. This means that there, and this is not surprising, that during the treatment, during the activation of TLR7 and the downstream pathway, there are changes in the composition. The cells are getting activated, and we know that actually TBNK cells are getting activated. They marginate, they disappear from the periphery, and remember we are analyzing here whole blood, and therefore the composition is changing. Those subsets that are staying in the periphery, macrophages, monocytes, neutrophils are getting rather enriched, and those that are disappearing are here the signature is getting blue, is dropping, but returning is temporary change. It's returning back 24, latest 48 hours post-treatment. We were looking on the immune activation as well, and what we also could see that there is some hints of activation of effector memory or the enrichment of effector memory CD8 cells, mainly observed in chronic HBV patients. What it will mean for our patients, how meaningful it might be for the treatment, hopefully we will see in the phase 2 study. And to the summary, we observed a high level of heterogeneity in the pharmacodynamic responses in healthy and chronic HBV study subjects. The transcriptional response is dominated by inflammatory signature, with some genes stronger deregulating in chronic HBV subjects. There are some specifics for those subjects. For many transcripts, see that the magnitude created with the second dose, and seems that the transcriptional response is mainly driven by monocytes and neutrophils. We of course know that the major target of the TLR7 agonists are the cells, the T cells that are expressing TLR7 receptor, but at those given time points, it seems the monocytes, neutrophils, macrophages are those that are accounting for these transcriptional changes that we can measure. Thank you for your attention. I also should thank to everybody on the team, on the TLR7 team, to investigators that are supporting the study and making that possible that actually the study happens. Thank you for your attention, and I'm happy to answer your questions.
Thank you, Dr. Radcek. The acoustics were not optimal, I have to say, but we go on. We started our session today with a presentation of Professor Gain from Auckland, where he gave a presentation on the effect of a TLR8 agonist. And you mentioned that your TLR7 agonist has some TLR8 activity, maybe hidden. So how much of what you showed may also be TLR8 related? And afterwards, I would like to ask Professor Gain to comment on his agonist, whether there is also some cross-activity towards TLR7. But please give a comment on that.
Thank you for this question. I hear myself a little bit. Indeed, we were including in our pharmacodynamic analysis markers that could tell us a little bit more about that, whether TLR8 receptor is also activated. We were measuring TNF-alpha, interleukin 12, 6, 10, also in serum, and we couldn't see some major changes in the serum levels of those markers. So giving us actually more feeling that this compound we don't see some major activation of the TLR8 pathway. Of course, there's the overlap, but between the TLR7 and TLR8 downstream signals, but that from that what we know about TLR8 pathway, we think we don't have some big activations there. And I'm happy to hear Dr. Gain comment.
May I ask Professor Gain to comment on that? Just about.
Yeah, good evening, Dr. Rajek. Ed Gain here. I've worked in some